Hello, my name is Ali Radmanesh. I'm the Director of Pediatric Neuroradiology at NYU Langone Health. Today we're going to have a brief case-based discussion of congenital malformations of brain and spine. For each disease entity, I'm going to show you a few images and a few seconds to formulate your opinion. Then we will point out the imaging findings and follow that with a teaching slide consisting of some facts about the disease entity of interest. Let's start with case number 1. We'll give you a few seconds to look at it. Okay, you probably noticed absent septum pellucidum on the coronal image at the level of the ventricles. We have absent or too small to identify pituitary stalk and small optic nerves. These findings are suggestive of septo-optic dysplasia, formerly known as de Morsier syndrome. Septo-optic dysplasia is a heterogeneous disorder loosely defined by any combination of optic nerve hypoplasia, pituitary gland hypoplasia, and other ventral or rostral intracranial midline anomalies. Approximately 2/3 of patients have hypothalamic pituitary axis dysfunction, and there are other associated anomalies including cortical malformations, ectopic neurohypophysis, and hypogenesis of the corpus callosum. We should keep in mind that isolated absence of septum pellucidum is quite rare. Therefore, whenever we see absence of septum pellucidum, we should look for other findings and make sure that we do not miss associated anomalies due to satisfaction of search. Case number 2, I'll give you a few seconds. You probably noticed frontal lobes are not separated or cleaved. There is partial fusion of the thalami, and there is incomplete or absent corpus callosum. These findings are consistent with a semi-lobar holoprosencephaly. The term holoprosencephaly means failure of prosencephalon to sufficiently divide. It could have genetic and maternal factors as their etiology, such as ethanol, diabetes, and retinoic acid. There are 3 types of holoprosencephaly. It could be very severe, also called Alobar, where the brain has not divided at all, and it usually associated with severe facial deformities. We have semi-lobar holoprosencephaly, which we just saw an example of, where brain has partly divided, and we could have the less severe end of the spectrum, which is lobar, and the brain hemispheres are considerably separate, and they're in fact nearly normal. So if we don't pay close attention, we may actually miss that small fusion between the thalami, which is sometimes the only sign of lobar holoprosencephaly. You see these examples of semi-lobar and alobar holoprosencephaly, and that is why some people say that face predicts the brain in terms of the spectrum of holoprosencephaly and how severe the disease entity is. These are some examples of subtypes of holoprosencephaly. We have lobar on the left-hand side with some fusion of the thalami, semi-lobar, which we just saw a case of, and alobar, where we have a monoventricle and lack of fusion of the cerebral hemispheres. Case number 3. You probably easily noticed the appearance of polymicrogyria in this case. Polymicrogyria is often acquired from a vascular insult during the course of cortical development. Signs and symptoms of polymicrogyria could vary depending on the location, but most common presentation is seizure. And as the term implies, polymicrogyria, there are numerous small gyri forming the area of involvement. The most common location for polymicrogyria is the perisylvian region, as you see in this case. Case number 4. This is a classic example of this disease entity where we see abnormally smooth surface of the brain with near complete absence of sulci, and lateral ventricles are often looking dysmorphic. As you notice, the shape of the brain is often reminiscent of an hourglass. This hourglass configuration and smooth surface of the brain with incomplete development or lack of sulcation leads us to believe that this is a case of lissencephaly. Lissencephaly is a spectrum, could range from absence of gyri or sulci called agyria to incomplete development of sulci called pachygyria, and to the least severe form of it, which is called band heterotopia. In fact, band heterotopia is often considered separate from lissencephaly, but we should keep them in mind as along the same spectrum. Like we said, lissencephaly means smooth brain, is a malformation of neuronal migration, could range from agyria to pachygyria. There are several causative genes identified for this condition, including LIS1 and DCX or double cortin. It is closely related to band heterotopia, like what we said earlier. They fall along the same spectrum. If we have a case of lissencephaly in a patient with facial abnormalities, we should think about Miller-Dicker syndrome or Miller-Diker syndrome, whatever you want to call it. And you see an example of it on this slide. Case number 5. In this case, we see nodular periventricular lesions that have similar signal on both T1 and T2 weighted images to the gray matter. Very classic for heterotopia, gray matter heterotopia, because of their location and their morphology. They're called periventricular nodular heterotopia. Heterotopia is a collection of normal nerve cells but in abnormal location, and therefore similar to lissencephaly, which we talked about earlier, they are abnormalities in neuronal migration. On brain imaging, the classic feature is that they are isointense to gray matter. The morphology could be nodular in periventricular location, could be nodular in subcortical location, or could be laminar or band-like. You see all three examples in the upper portion of this slide. An important point, especially for the sake of exams and also in real life, is to remember that heterotopia does not enhance and does not calcify. And that is unlike what we know of subependymal nodules in tuberous sclerosis complex. Therefore, as you see in the red box at the bottom of this slide, if you see subependymal nodules that are calcified or develop enhancement on post-contrast images, we should suspect more that to be a tuberous sclerosis complex subependymal nodule rather than periventricular gray matter heterotopia. That's an important clue that becomes handy. Case number 6. As you notice, we have blurring of gray-white matter junction and T2 hyperintensity in the cortex and subcortical white matter. This is an example of focal cortical dysplasia. Focal cortical dysplasia often presents with seizure. Sometimes, particularly if there is associated expansion, we should also think about low-grade glioma, and sometimes the distinction becomes difficult. So we end up following the patient for a while to see if there is any growth to favor low-grade glioma, or if there is long-term stability, which would favor focal cortical dysplasia. If focal cortical dysplasia is extensive and associated with enlargement of part of or entire hemisphere, it is called hemimegalencephaly. Remember that the more acceptable term for hemimegalencephaly nowadays is dysplastic megalencephaly. So both terms are still used, so we should be familiar with them. Hemimegalencephaly and dysplastic megalencephaly are essentially referring to the same concept. In the red box at the bottom of the slide, you see examples of hemimegalencephaly, and on the right-hand side, you see different types of focal cortical dysplasia. Discussion of the imaging patterns of different types is beyond the scope of this brief talk, but you can certainly look that up and find out the differences. But one imaging feature that is pretty important is the blurring of gray-white matter junction and the subcortical white matter T2 hyperintensity. Case number 7. In this case, we notice dysmorphic appearance of the cerebellar vermis. You see that the vermis doesn't have the classic lobes and lobules and the classic fissures and folia. It has a lumped and dysmorphic appearance. In addition, and more classically, we see thickening of the superior cerebellar peduncle with horizontal orientations, giving that part of the brainstem a molar tooth appearance. This is an example of Joubert syndrome and related disorders. Joubert is associated with other anomalies, could be in the kidneys, in liver, or in eyes, in the form of coloboma, retinal dysplasia, multicystic dysplastic kidney, hepatic fibrosis, or even polydactyly. In terms of symptoms, they could present with ataxia, dysmorphic face, global developmental delay, hypotonia, rapid breathing, and even more classically, oculomotor apraxia. And this is an example of Joubert syndrome and related disorder. Case number 8. In this case, you notice cerebellar hemisphere lesion that has some T2 hyperintensity and T2 iso to hypointense signal. It has some mild regional mass effect. The T2 weighted images show a striated or gyriform pattern in the region of the lesion. But on the post-contrast image, we really do not see any post-contrast enhancement. These are classic imaging features of Lhermitte-Duclos disease, other name for it, which is probably more scientific, is Dysplastic Gangliocytoma of the Cerebellum, is a Hamartomatous lesion. Therefore, it does not show growth, or the growth that it shows over time is very, very slow. Having said that, in WHO 2016 classification, Lhermitte-Duclos or Dysplastic Gangliocytoma is considered a grade 1 tumor, and we should keep that in mind. Many of Lhermitte-Duclos are found incidentally. However, they can also present with headache, ataxia, cranial nerve palsy, or hydrocephalus. Most cases have Cowden syndrome, which entails multiple hamartoma neoplasia syndrome with P10 mutation. The neoplasm could involve thyroid, breast, GI, and GU. As we see in our case, there is usually some associated regional mass effect, but not a whole lot of edema associated with Lhermitte-Duclos, and usually enhancement and calcification are rare in this entity. Case number 9. We see an interesting appearance in this cerebellum because the cerebellar vermis appears to be absent and there is continuity of cerebellar parenchyma across midline. This is the classic definition of rhombencephalosynapsis. There are associations with rhombencephalosynapsis, including other midline anomalies in the supra or infratentorial parenchyma, aqueductal stenosis, and as a result of that, hydrocephalus. Rhombencephalosynapsis could also be seen in association with lacteal sequence, and we should keep that in mind. You see another example of it in this slide with continuity of the cerebellar parenchyma across midline. Next case. This is a case from literature. See, quite impressive. Pay attention to the location and what is happening to this child's brain. In this example, we have an occipital encephalocele. You see that we have a defect in the lower occipital and upper cervical region, and we have extension, extracranial extension of CSF, part of the meninges, and also definitely some of the parenchyma in the region of the cerebellum into this encephalocele. And as a result of the downward extension of the parenchyma, we have tectal beaking. And on the spine image, we see a holochord syrinx. These set of images are what we see in the setting of Chiari-3 malformation. We are used to looking at Chiari-1 and Chiari-2, but we do not usually have a lot of experience with Chiari-3. So it's good to keep them side by side and remember them as one set of entities, even though they're really different diseases. But what they have in common was that they were described by the same person, Dr. Chiari. On the left-hand side, you see Chiari-1 malformation, which is a consequence of a small posterior fossa. The middle case is a Chiari-2, which is the result of a lumbar myelomeningocele, and Chiari-3 is very similar to Chiari-2 in terms of the pathophysiology, but the area of encephalocele is in the occipital or upper cervical region rather than in the lumbar region. And as you can imagine from the involvement of the brain parenchyma, these are usually associated with poor prognosis. So this was a case of Chiari-3 malformation. Case number 11. Give you a few seconds. As you notice in this case, we have a sinus tract at L5S1 level, which extends to the posterior skin surface with no obvious connection to spinal canal or to the dura. Over the top of that sinus tract, on the skin surface, there is a superficial mass at that level, which shows enhancement on the post-contrast sagittal image, which you see on the right-hand side of the slide. And that mass is likely a hemangioma. This is a classic imaging feature of dorsal dermal sinus. The best diagnostic clue is a hypointense sinus tract superimposed on hyperintense subcutaneous fat. So usually a non-fat saturated T1 weighted image is key to easy identification of a dorsal dermal sinus. The osseous findings range from normal to a groove in lamina or spinous process to the extreme of multi-level dysraphism. So we could have a range of different osseous findings. If dorsal dural tenting is present, then it means that there is dural penetration by this dermal sinus. In terms of the conus position, if the sinus is in the lumbosacral levels, it is usually associated with tethered cord and low-lying conus. But if the sinus is at the thoracic or cervical levels, the patient often has normal conus positioning. Case number 12. Give you some seconds to look at. In this example, we see splitting of the spinal cord. We see what looks like a septum in between the two half of the spinal cord. It appears that the interior aspect of the septum is bony and the posterior aspect is fibrous. It's hard to make that determination on MRI. We usually can easily make that distinction on CT if it is necessary before the surgery, but regardless, there is usually a fibrous or bony septum in between the two parts of the cord. And we also have an intradural lipoma adjacent to the dorsal aspect of the split cord, as you see on the sagittal images. This is a case of diastematomyelia. In terms of location, the most common location is thoracolumbar levels. 85% of cases take place between T9 and S1, and much less commonly they can be seen in upper thoracic or cervical levels. As we said on the previous slide, we could have osseous or fibrous spur. Cutaneous stigmata on the back are suggestive of diastematomyelia level in more than 50% of cases. For example, most commonly a hair patch could make that indication. And it's important that whenever in a patient we see cutaneous stigmata or intersegmental fusion of the posterior elements or clinically tethered cord, we think and we search for diastematomyelia on our imaging. Case number 13. So right off the bat, you notice that this is a quite abnormal spine. First of all, the entire length of the spine is shortened, and the bottom part of the spinal cord looks truncated and blunt. So it's a severe caudal regression syndrome. We really do not see a well-formed sacral or iliac region. Looks like the bottom of the spine and lumbosacral region is truncated. There is lumbosacral agenesis as well as agenesis of the lower thoracic vertebral bodies, and spinal cord terminates at the level of what appears to be T4 and demonstrates a blunted end appearance. This is an example of caudal regression. Is a dysgenetic lumbosacral vertebra with abnormal distal spinal cord. The spectrum could range in severity from absent coccyx, which is not that severe and could be completely asymptomatic, to complete lumbosacral agenesis, as we saw in the last slide. Case 14 and the last case. As you notice, there is abnormality and multi-level fusion in the visualized portions of this curved cervical spine. We have multiple anomalies from C4 through C6. Vertebrae are fused together. The facet joints are fused throughout the cervical spine on both sides. And spinous processes are absent from C3 down to the cervicothoracic junction. The combination of these findings are suggestive of Klippel-Feil Syndrome. It could be a single or multi-level congenital cervical segmentation and fusion anomaly. The most common involved level is C2, C3 in 50% of cases, then C5, C6, and then craniovertebral junction and upper thoracic spine. And it is felt to be caused by failure of normal segmentation of cervical somites during the 3rd to 8th weeks of gestation. Klippel-Feil Syndrome. I really appreciate your attention, and I hope that you found this quick case-based review helpful. This was not intended to be a comprehensive review of such a complex and extensive topic, but I hope that that gives you enough insight into some of the most common and most important entities that we have to be aware of as radiologist. Good luck to you.